Good afternoon, everyone. I would like to share with you some few management of hepatocellular carcinoma. Hepatocellular carcinoma, HCC, is a global cancer because of its high mortality. And one way of managing hepatocellular carcinoma is through surgery. And I must say that surgery has become the most important modality for managing hepatocellular carcinoma. There are other modalities used for managing hepatocellular carcinoma, including chemotherapy, radiotherapy. A combination of these modalities is always important in the management of these patients. Today, I will share with you the surgical management of HCC. The actual prevalence of HCC is unknown in most sub-Saharan countries, and this is because of lack of data in patient management. In Ghana, HCC is common, and it is believed to correlate with the prevalence of chronic hepatitis B. The prevalence of chronic hepatitis B ranges between 8 and 13% in Ghana. So we see a lot of HCC patients. We actually don't know the actual prevalence, but we believe it correlates with the prevalence of chronic hepatitis B. Surgery offers the best chance of cure or long-term survival in these patients. Surgical options that are available for HCC include liver resection, which is used as a definitive treatment, or liver resection acting as a bridge for liver transplantation in selected patients. The second option for treatment of HCC is liver transplantation. In the process of selecting candidates for surgery, these factors are considered most important in order to have better outcomes. We look at the patient's performance status. We look at whether the disease is multifocal or localized to one lobe, and whether the remnant liver is adequate for survival. It is important to note that you need about 30% of the total liver volume as remnants to have a safe liver resection in order to avoid or prevent the risk of postoperative liver failure. In situations where there is cirrhosis of the liver, then your remnant liver is now compromised, and you need to assess this patient's liver health according to the Child-Pugh score to determine whether this major resection is safe in these patients. Whenever there is macrovascular invasion or distant metastasis, this has to be put into the consideration in the selection of candidates for liver resection. Preoperative planning is key to impact the outcomes in these patients. Usually a combination of bone scan, CT scan, or MRI, and in centers where PET scan is available, this is done to stage the tumors. So as clinically, you look at the performance status of these patients and the Child-Pugh score, these imaging modalities will help you to stage these patients for liver resection. Liver resection without chronic liver disease is safe in patients who you have about 30% of remnant liver. 30% of remnant liver is adequate and safe in these patients when they undergo liver resection. The risk of postoperative failure, liver failure, is low. So major liver resection is safe in these patients. In some instances, there might be multifocal liver disease where you see a tumor in the right lobe or in the left lobe with an isolated nodule in the contralateral lobe. In these patients, it's possible to resect one lobe and do a non-anatomical removal of the nodule, which is about 2 or 3 centimeters in the other segments. Because there's no background cirrhosis, this is safe and avoids postoperative liver failure. Is liver resection okay in patients with metastatic disease, lung mets, bone mets? This is usually a choice of the surgeon and the outcomes. For metastatic disease, the best option will be systemic therapy. But we have found in our center that for patients with resectable HCC, in the setting of bone metastasis or lung metastasis, resection provides a better quality of life for these patients. There is no pain. Patients live with a better quality of life, even though it might not impact on the survival. Quality of life is improved when these patients undergo liver resection. If you look at the segmental anatomy of the liver, it is possible to resect the right lobe, functional right lobe, which is from segment 5, 6, 7, and 8, and then also remove an isolated nodule, which is in segment 2 or 3, and still have a very low risk or none at all of postoperative liver failure. So in these patients, even though the disease is multifocal, liver resection still suffices when there's no chronic liver disease. You see this slide that shows a patient who had a right lobe HCC. Patient had right hepatectomy. So remnant liver has segment 2, 3, and 4. And in this patient, you see this is a normal liver, no chronic liver disease. So postoperative failure is almost not existent, and patients' recovery and outcomes are better. But in a setting of a chronic liver disease, liver resection must proceed with caution. Thorough preoperative assessment, risk assessment, is key to good surgical outcomes. The patient's Child-Pugh score must be determined, and major resection can proceed in the setting of Child A cirrhosis with good outcomes. And there has to be a bit more caution when the patient belongs to Child B cirrhosis. When it's Child B cirrhosis, 1 or 2 segment liver resection may be okay and prevents liver failure, but a major resection should be avoided in Child B cirrhosis. Child C candidates are not ideal candidates for liver resection in the setting of HCC. So such candidates, other modalities must be used because liver resection is unsafe in such patients. This is a patient with HCC in the background of cirrhosis. This patient belonged to Child A cirrhosis, and major liver resection was done and outcome was good. But if it is determined that these patients have chronic liver disease in the class of class B and C, then major resection should be avoided. Liver transplantation is a superior option that ensures cure in patients with HCC. There is a strict criteria that should be used called the Milan criteria. And in these patients, they might have tumors not more than 3 nodules, and each nodule should not be more than 3 centimeters. If the size of the tumor is 5 centimeters, then it has to be a single tumor. This strict criteria ensures a low recurrence rate and a better long-term survival. In some centers, patients have been transplanted outside the Milan criteria. And this has been in situations where liver resection has been used as a bridge for liver transplantation. So these patients underwent liver resection, and then after 3 months, they are restaged. And if there's no evidence of disease recurrence of disease progression, then these patients will qualify as candidates for liver transplantation. Transarterial chemoembolization can also be used as a bridge for liver transplantation for patients who are outside the Milan criteria. So TACE is done for these patients. Systemic therapy is given to these patients. After 3 months, patient is restaged. If there's no evidence of disease progression or distant metastasis, these patients are now selected through the criteria for liver transplantation. I must say that in some settings, as high as 20% recurrence rate is seen in these patients, most likely because of inadequacy of staging. There are major challenges that face patients and clinicians in the setting of HCC in Africa, especially in West African sub-region. Patients present very late with HCC, and most reasons because of access to healthcare, and also because patients seek alternative care before coming to hospital. So they present very late, and not many of them are candidates for liver resection. There is lack of human resource for management of HCC in most parts of Africa. The skill for surgeons to resect liver tumors is lacking in many countries in West Africa, and this becomes a huge barrier in the management of HCC. Financial constraints, such as lack of insurance that pays for these patients, becomes a major challenge and a barrier in the surgical management of HCC. In centers where surgeons are capable of providing surgical services for HCC, lack of equipment also adds to the barrier in the management of these patients. In conclusion, surgery remains the most important treatment option for the management of HCC towards possible cure or long-term survival. The surgical capability for HCC treatment is lacking in most sub-Saharan Africa, and prevention and modification of risk factors for development of HCC would play a major role in reducing the disease burden and death from HCC. And that should be the primary goal of all clinicians who manage hepatocellular carcinoma. Thank you very much for your attention.